Well, thank you for coming in. I know today has been a long one,
Yes, it's
so we
been long,
appreciate your time.
but I'm here, and
Yep,
this is the time we get to spend with each other.
so excited. I'm going to just start by reading your bio. You are a board certified OBGYN affiliated with Baylor University Medical Center, founder of Sanctum Med and Wellness, where you combine traditional and holistic approaches to women's health, and you are also the chief medical officer at HERS. With a focus on perimenopause and menopause, you go beyond the biological effects, addressing the emotional, physical, and lifestyle aspects to offer comprehensive support for women during these transformative stages.
Yes.
So we're so excited to talk to you. I reached out to our audience, so we have a ton of questions we're going to go through.
Let's go through them
Um,
all. I think the
yeah.
questions are, one of the most important parts of when I see women is hearing their stories and then hearing their questions. And I always say that one question is going to help someone else in return, right?
Mm-hmm.
So there's
Yeah.
no question that is too little or too big. It's all to help the community.
Yeah, I think that's usually how we feel too when we do
Hmm.
AMAs. We kind of
Yeah.
ask questions and then you realize other people have a lot of the same feelings or are going
Hmm.
through something similar. So this is great.
Yeah.
To start, I'm curious, for your friends, how many of them, how often do they reach out to you for medical
Oh,
advice?
I love that. I think because I have created obviously a platform where I do a lot of public speaking or do media, I think now they feel more comfortable coming to me because they know that at least I will give some time and space to them.
Mhm,
And the best thing is that I like to present it in a reassuring way because most of the questions that I find that do come towards me, even when they're from my friends, are of concern, hesitancy. And so the most important part that I can do is create reassurance and
mhm.
then giving them the education behind it. Yeah.
Nice. And then I know obviously you've been in school, you were in school for a long time.
Oh, such a long
Um,
time.
so I'm curious, once you started
Yeah.
practicing in the real world,
Hmm.
what was kind of the hardest lesson learned, compared to what you're taught in school versus practice?
I think the hardest lesson to learn was all the theory and evidence that we learned, which was crucial and very important to schooling because at the end of the day, that's what we're known for and that's
Mhm,
where our expertise lies. The one thing that was the hardest is now to translate that into experiential, into relationally how people experience symptoms or a
mhm,
disease or a condition. And so taking that evidence and that fact and bridging it into how each woman presents and every
mhm,
time they walk into my office is going to be a different story behind it.
mm,
And so that's where I really learned over the years is to listen to the story that comes with it because I know the fundamental parts of it. I know the resources and the treatment options and the management plans like the back of my hand, which is why I spent so much time in school.
mhm.
But creating it in a way where relationally they can actually use the evidence base and the research that I give them because I'm putting it back to them in a way where it's useful.
Nice. Yeah, that makes sense. And then I guess to start, uh, this a lot of this conversation is going to be focused around perimenopause.
Hmm.
So I think it would be helpful. I know recently in news and media, there's been a lot of conversation about perimenopause, but I know for myself, and a lot of people around me, no one really talks about perimenopause. It's just menopause.
Right.
So I'd love to hear kind of your definition of what perimenopause actually is.
Menopause, you're correct, has been the term for years, for
Hmm.
decades, that we really put more emphasis on because it was categorically a strict transition into, right? So, not having a period for 12 months was when we could categorize you as menopause. So, it is very definite, right?
Hmm.
But perimenopause is much more fluid and abstract in the sense that it can be 3 years, 7 years. There's no real telltale sign of when one woman is going to start and when one woman is going to end. And that makes it sometimes a little bit more confusing or chaotic. And so the definition behind it is that transition of time, which again can last from very little to a long time, even 10 years,
Hmm.
of when hormonally your body is going through the decline in how it produces and responds to estrogen, progesterone, and testosterone. And namely estrogen, because that's where we do see where a lot of the symptoms start to increase, because as estrogen goes down, the symptoms will increase. But it really is that transition in where women will notice changes in their cycles. They may become more regular, whether that's with flow, duration, or frequency, but also these other very kind of overlapping, maybe overwhelming, maybe not, symptoms of hot flashes, night sweats, irritability, decrease in libido, changes in sleep, and a lot of different bodily kind of functionality that starts to waver or wax and wane. And that
Mm-hmm.
is a little bit harder to put your finger on, which is why it was hard to discuss in the past, because it was so fluid. And so it
Mm-hmm.
really is this transition. And that's why I say body awareness is so important, because every woman will go through it differently. And
Right.
who am I to saying you are or you aren't, or what the intensity of one symptom is versus the other? And that's why it really was a difficult time for women to explain and
Mm-hmm.
express. And so giving words and context to it now that we have a better handle on it, and being able to help women understand that, I think is the game changer in going through this like really weird transition and then now putting words to it.
Mm-hmm. Yeah, and I guess I'm curious now that people are starting to talk about it, kind of what the future for perimenopause looks like. Do we feel
Hmm.
like GPs are prepared to talk about it now, or are they
Yeah.
still learning about it?
It is still so very new
Mhm.
in what we know about it. I'd even say in the evidence behind it. We have much more evidence and literature behind it, but not enough where we could say it's widespread that GPs or PCPs, nurse practitioners, other disciplines will know about it readily. And I think that's what we're looking for. And what I'm hopeful for is that we will get to a point where it's much more fundamental in
Mhm.
what it is, being able to acknowledge it, being able to discuss it, describe it, and then also provide the treatment and options that a woman can experience or at least explore while she's going through this time frame. So we're not there. I know we're going to get there, but it's going to take time.
Mhm. Do you think, I guess, how does tracking your cycle leading up to that first conversation with your doctor, how does that look? Do you find that to be helpful?
Yeah, I think that's one of the first indicators of, oh, something's going on, right? Is the
Mhm.
cycle, the changes in the cycle. And granted, it doesn't happen to everyone. There's probably a good number of women who are like, what is going on with
Mhm.
their cycle? So I think tracking cycles is one of the first, maybe like kind of, notes to your mind of, hey, something's happening, tracking it. And also, what comes with that too is making sure that it doesn't create anxiety. I think that's usually why women come to me in the perimenopausal phase is my cycles are either not as frequent, or they're heavier, they're lighter, they're just different in whatever that looks like. And so I think tracking cycles are important.
Mhm. Is it possible to have, I guess, what would be called a completely normal cycle and still be going through perimenopause? I know there's a slew
Yes.
of symptoms, but
I think that that's where, again, it becomes confusing, because what we do attribute to, we always want maybe a classic feature, right, of
mhm.
what something looks like.
Yeah.
And the classic feature of perimenopause is the change in cycles. But I have plenty of patients who have a regular cycle and they may be even 51, 52, 53.
Mhm.
But that doesn't mean that they're not perimenopausal. And that's why we need to look at it more from a objective point of view, and more of like a broad lens than it can only be change in cycles, which allows you to enter the phase of perimenopause, because that's just not true.
Right. And then I know you kind of touched on age a little bit. When
Mhm.
does it typically start? How long can it last?
Typically, what we have seen is when we look at kind of the statistics of when your hormones start to change,
Mhm.
can be in your early to mid 40s of what we start to see
Okay.
as it's starting. What I
Okay.
have began to notice is there are some women who are in their late 30s might have some certain shifts and changes, whether it's their cycle and or some symptoms, which again, I can check their hormones on a lab, but because they're telling me subjectively that they're having these changes, I do now kind of create more of an expansion in my lens of saying maybe they are perimenopausal and maybe they are early to it, but that doesn't mean that they're not going through it. So I would say
Mhm.
early to mid 40s is when most women start, but you do have some that start in the late 30s.
Wow. Okay. Is there any connection to when you had your first period? Is there?
There is some connection to the earlier you start your period, the earlier you start kind of like the menopausal transition. So perimenopause into menopause transition when we're looking at from a symptom perspective.
Mm-hmm.
But there, again, I feel that the environment plays a factor in that. I think that ethnicity plays a factor in when you'll start. I think also your stress levels. And what we have been seeing as later pregnancies is there sometimes seems to be this very quick transition into late pregnancies in the postpartum phase. So women who might have their children may in the early 40s or late 30s.
Mm-hmm.
And then as they come out of that postpartum phase, kind of stay on this course now of kind of changes in symptoms and irregularity in cycles. So I have started to see that as well.
Okay. Is there any connection to how many kids you have? Like, does giving
No,
birth
there's no real
kickstart?
connection to how many kids you have because most people, if they do have usually a lot more kids or many kids, I would say that maybe greater than three, usually
Mm-hmm.
started earlier.
Okay.
And so maybe they've finished their childbearing years in the early 30s to mid 30s.
Mm-hmm.
But you do have some who have a lot of kids and maybe have their last kid in their 40s. So that really doesn't place too much emphasis on it because it really depends when you had all those kids.
Got it. Okay. Is there any, I guess, kind of coming off the parental side of things, with your mother? Is there any connection there? Like
There
your
is a
mom's
connection
experience?
between the menopausal transition of asking, I ask patients, are you aware of when your mom went through the menopausal transition? Now,
Mm-hmm.
there is a correlation to that, that most likely you will have that kind of transition into menopause around when your mother had menopause. What I have found is the generation before, so for women who are going through perimenopause now, most would say that when they do talk to their mother about the menopause transition, they're either unable to get that correct information. And a
Mm.
lot of that had to do with for decades, we've seen that women have kind of shunned it, something you don't talk about. It's a little bit taboo or embarrassing. So
Mm-hmm.
there is no real true recollection of what was going on with them, who is informing them. Doctors weren't talking about it. And so it's kind of like something happened, they're not quite sure what, and then they just went into menopause. And so there was no discussion around it. There's no timeline. And so to give that information back, to your daughters who, we're the generation who are asking every question,
Mm-hmm.
you don't see a lot of that information sharing.
Okay.
And so I think what we are seeing now is from this generation and the ones behind us, this will be much more of a vibrant, involved, engaging conversation.
That's great.
It is great.
Yeah, it's refreshing. In terms of the hormones, I know you touched on the different hormones that are changing. Can you walk me through a little bit of what is actually shifting with our
hmm
hormones?
When we look at biologically, and I guess you could say from a neuroendocrine or endocrinology perspective, progesterone actually is the first of the hormones that is impacted uh, in that perimenopausal transition. And that can happen again in your late 30s, early 40s. And then we start to see a decline in estrogen. And as that decline occurs, that's where we start to see a lot of the symptoms start to emerge. But
Mm-hmm.
also, there's a shift in testosterone as well, which a lot of women are unaware that they have testosterone. But testosterone is actually one of the most potent hormones in women. There's
Hmm.
in smaller doses than we typically see testosterone levels in men. So it doesn't mean we don't have testosterone, we just have smaller amounts, but testosterone is a very potent hormone. And that also starts a very steady decline as well in the mid 30s, too. So it really is this fluctuation of all of these hormones, namely progesterone, estrogen, and testosterone. And then eventually that's why we're able to somewhat categorize perimenopause into stages, right?
Mm-hmm.
So your early and your late stage of perimenopause into your early and late stage of menopause. And that has a lot to do with how much of the decline you will start to see of those hormones as you go into each of those phases.
Okay, that's very interesting. Yeah, because I think we learn about it in premenopause,
Yeah,
but you don't really talk about how it changes throughout.
yeah,
That's
lots of
interesting.
fluctuations going on. And that's why I feel that perimenopause, and I'm glad it's becoming more of the center of discussion,
Mm-hmm.
is the most chaotic, confusing time because in someone's mind, they're like, well, I'm not menopausal because I still have my period, albeit it may be irregular. but
Yeah.
I am feeling out of my body and
Mm-hmm.
out of my mind, and I'm not quite sure where to place it. And why I have these symptoms, then they'll go away, then they'll come back. And so that can be quite frustrating. And I think that once we kind of bring it all together and allow everyone's experience to be shared in it's not one picture of it, will
Mm-hmm.
allow women to feel more comfortable discussing it.
I am curious with these kind of symptoms like fatigue, brain fog, feeling out of your body. A lot of
Mhm.
those I mean, at least I sometimes will experience when I'm in my, uh, dreaded luteal phase.
Mhm.
So, how do you know the difference between what you normally are experiencing versus is it just ramped up a bit? Like, how
Yeah.
do you know it's perimenopause?
That is where we get the subjective part of what someone's able to give towards their experience, right? And how they're
Mm-hmm.
able to kind of collect data, I guess you can say, or historically bring it to a healthcare provider to say this might be the same and or different.
Mm-hmm.
Everyone usually has a good kind of handle on what they've done for years throughout their cycle and some of the phases of moods that they go through according to where they are in their cycle. Into now, this is shifted to something a touch different or very different. And
Mm-hmm.
that's where self awareness is so important. And that's why I think that the conversation around it needs to be even more and more because the more that people hear other people's experiences or why it happens, then they can also touch base with themselves and saying that, yeah, this is different to what I usually feel throughout my cycles. And I need to address it or pay more attention to it. Because it doesn't always mean that if you're going through something different, then you have to do something about it. But
Right.
it is very important to be aware of it.
Mm-hmm. And then I guess for those of our audience who are kind of just getting to that point of feeling like something might be off, I think for a lot of people it feels really daunting. So,
Hmm.
what's kind of the piece of advice, or, I don't know if you have a mantra or something that you say to people that are kind of just getting into this phase that might feel overwhelmed?
Yeah, I always do like to actually start with the mantra of you are not alone. I
Okay.
think you are not alone kind of just allows you to take a pause and being like, whatever I'm going through, whatever it is,
Mm-hmm.
even if I'm not like fully aware of what it is, I'm not alone
Mm-hmm.
because women are going through this. Now, the other thing is I deserve help or care
Mm-hmm.
in the sense that you're going to go seek it. And that can be through community, it can be through talking with your healthcare provider, or maybe having to find another one. And then also, using telehealth platforms as a way to kind of get more directed care and seeing where you fall into that. But I have started to see that community does play a significant impact on how people are able to relate to what they're going through in their life at that time. And also being curious and being curious to the availability of options that you are because as you start to go through it and feel maybe discomfort or frustrated or disappointed is that there are options out there that you do not have to suffer.
Mm-hmm. And then I know, I guess speaking to the curiosity a little bit, I think just because I've been talking about perimenopause a lot, it's
Yeah.
starting to show up in my algorithm. And there are some kind of, I guess, odd, for lack of better words, symptoms that I'm seeing.
Hmm.
So, like one smelly armpit or itchy
Yeah.
ears. Like, what are these kind of lesser known symptoms? Like, I guess,
Right.
what causes
So,
that?
two different things. One, the experience of perimenopause and menopause is an entire body kind of experience because we have receptors for estrogen, progesterone, and testosterone all throughout our bodies. And I
Mm-hmm.
think we somewhat typecast it to just the pelvis. So we're like, well, yeah, I know my cycles are changing and, maybe I'm not able to get pregnant anymore. So that's a fertility aspect, right? And so
Mm-hmm.
it's very reproductive, pelvic focused. But when you, again, start to see that you have receptors in your muscle, in your bone, in your brain, in your heart that all respond to these receptors, it makes sense why you're starting to have these different symptoms, which may feel very like out of the box, such as the ones that you mentioned with ringing ears, itchy skin. Mood for a long time was never associated with the perimenopausal phase.
Mm-hmm.
And so I think that once you understand the connectivity between hormone regulation and its optimization and levels, and when they are not at the levels that they should be, when they're different, when they're declining, you're receptors are not able to respond to them because there's not any around. So then you're starting to put the pieces of the puzzle together that this really is I guess if you wanted to call it a neuroendocrine kind of phenomenon,
Mm-hmm.
obviously a hormonal phenomenon, but it really is a whole body transition.
Mm-hmm. That makes sense. And then in terms of pregnancy, is it still possible to get pregnant during
Ooh, I
perimenopause?
love this question because perimenopause is that like yellow light before you get to red light, if you
Okay.
wanted to look at it. When
Yeah.
we think of in terms of fertility, I would say, obviously you have your outliers, but your green light would be from the time that you start your period,
Mm-hmm.
as far as ability to get pregnant, all through adolescence, your 20s, your 30s, and we know after the age of after the age of 35, your ovarian function and ability and decline starts, right? So your function kind of decreases. The ability for you to get pregnant is harder.
Mm-hmm.
And also the quality of your eggs. And that has a lot to do with the decline of the hormones.
Mm-hmm.
So as you pass the age of 35, it doesn't mean you can't get pregnant. It's just a little bit more difficult. And then as you get into your early 40s and your mid 40s, that again is declining. But the likelihood is less, but it doesn't mean it's impossible. So that's why going through this phase is just because you may have had, I don't know, making up a number, 5 periods a year or cycles a year rather than every month. That doesn't mean you can't get pregnant. So in the counseling of the perimenopausal stage is also to, as we address your symptoms and maybe consider some therapy such as hormone replacement therapy or menopause hormone therapy,
Mm-hmm.
is that you can still get pregnant and that's not a substitute for contraception.
Yeah.
So you actually have to have both conversations.
Okay. Yeah, that's interesting. Um, I guess just in general, I think this conversation is unique in that a lot of the conversations online and in the media about perimenopause, at least right now, are pretty bleak. And I think
Mm-hmm.
a lot of people aren't super excited to
Mm-hmm.
enter perimenopause. It does
Yeah.
feel quite scary.
Mm-hmm.
Do you feel like there is, I guess I'm curious what your idea of, on the opposite side of the spectrum of that, what is the bright side of
Mm-hmm.
perimenopause? I know hopefully
Yeah,
there.
the bright side is if we had a different idea or ideation of aging, then
Mm-hmm.
maybe we could start to change that. I think society, when you really look at it, I mean, it is very deeply rooted in kind of a patriarchal societal idea of what women's worth is.
Mm-hmm.
And a lot of where we place that emphasis is on fertility. And so as that starts to decrease, as we start to age, comes this notion that our worth for what we are able to provide
Mm-hmm.
to the world. I mean, this is really like caveman, if you think about it's just modernized up until now,
Right.
is that our worth declines and it's not worth talking about. And it's somewhat of like this embarrassing phase to enter. So once we
Mm-hmm.
kind of actually look at where we have created women to evolve and be more innovative as far as in society for themselves, being independent. That's a lot of times where you see women's careers start to rise, right? Is
Yeah.
in your 40s in the perimenopausal phase.
Right.
And so the aging kind of moniker alone, I think if we could change that, then women would maybe being like, wow, this is a great phase of my life because if fertility is declining and, I'm not able to get pregnant, I don't have to worry about getting pregnant, if you wanted to put it as a kind of thing that you can look forward to. And I don't
Mm-hmm.
have to pay so much attention to if I want to get pregnant or not.
Right.
And then also I have the ability and the freedom a lot more times to do what I would like to do. So it kind of creates this freedom era. And I think that if we looked at it more with that lens, then it wouldn't be so entering the phage begrudgingly.
Right. Okay. And I know you just spoke a little bit about kind of how women, I guess it seems like, need to advocate for themselves a
Yeah.
little bit more. So I am curious because it's not just the perimenopause stage,
Yeah.
but I guess for the purpose of this conversation, with it being kind of a new area, how do you think women can better advocate for themselves in a
Mhm.
system that hasn't always recognized perimenopause?
I've always said the best way that women can advocate for themselves is if they utilize themselves in groups and numbers,
Mm-hmm.
right? And so typically there has been a very concerted effort to divide women amongst their own interests, right?
Mm-hmm.
Among interests that will serve them better. And so once women start to see that they can advocate for themselves and others, even if that thing doesn't necessarily have a interest in them individually,
Mm-hmm.
then that's where we'll start to see movement in how policy is written, having more women represented in levels that do make change and shift, controlling the economy of women's health, looking at research. So,
Mm-hmm.
all of these different parameters that eventually do feed into how women are able to show up for themselves in society has to be a stronghold of a group of women, a strong, large group of women. So, the more that we pit each other against ourselves based on interest, and just band together for the good of women and what we all deserve,
Mm-hmm.
I think that's where we'll start to see change, because I think for so long women have had to fight for very simple freedoms. Hey, I'd like to vote. Oh my gosh, I think I'd like to have a checking account.
Yeah.
Like simple things. And now when it comes to our health, because women typically live longer than men, but we live our lives towards the end of our lives in poorer health.
Mm-hmm.
So, if we're going to advocate for ourselves to be our best selves, especially since we're living older, then we have to start now. And
Yeah.
this is actually the best time frame to start making those changes.
What lifestyle changes can women who are going into perimenopause, I guess, walk me
I
through?
think
Health,
this is
diet.
maybe my favorite topic ever. And the reason why this is my favorite topic is that's what's going to be like your long-standing framework that will hold you up in a pinch when you're
Mm-hmm.
70, 80, and 90 is your lifestyle, because that's where the routine is set. That is what your body fundamentally can rest assured on, is that you've given it the best framework possible through lifestyle. And when I say lifestyle, I specifically mean nutrition and exercise,
Mm-hmm.
also movement, right? I like to put that in the same category because sometimes people think that exercise is very intimidating, just like from the word and what we have labeled it in society. And so, nutrition and exercise to me are the most important lifestyle factors, because, like I said, it creates a framework, but it is the consistency that will get you the best outcome, right? So,
Mm-hmm.
it's not, and, nothing is ever linear. Everything has movement and flexibility to it in our lives. And so when we're able to create consistency in the form that there will be small changes, some days that are not good, some days that are bad, but you really keep that framework within small fluctuations and it's not kind of all over the place, which is typically what you see in the diet world, right?
Mm-hmm.
Do this thing for 4 weeks and then what? Go back to your regular scheduled program. That never works. And that has always proven to not have the best outcome.
Mm-hmm.
So, lifestyle happens, or helps rather, because your cellular aging process is real.
Mm-hmm.
And one of the ways you can be the most preventative and proactive against how your cells become what we call senescent, which is like quiet and kind of like growing old, because that's what
Mm-hmm.
happens in the aging process, is to fortify it with the everyday things that you surround it with. And so what we have seen in women specifically is protein does make a big difference in how your body's able to utilize the protein that you're ingesting in order to then help the cells, in order to help muscle mass, in order to help brain function. So there's so much importance to that. But if we're not told exactly what those shifts need to be done, a
Mm-hmm.
lot of times people are just unaware, or they were just not educated in the nutritional fact of what's needed. I think supplements can be very helpful because a lot of women come into my office and might be deficient in things like vitamin D, vitamin B12,
Mm-hmm.
maybe even iron. And these things all have an impact on our bodily functions. So if they're already deficient, why am I going to wait till you have a bad outcome with it rather than helping fortify it or optimize it as it's starting to be in its lower phases?
Mm-hmm.
And then with movement and exercise, we just because we're more sedentary, just because of literally innovation and technology, right? So things can happen in our lives without us having to manually do it or physically do it. And
Mm-hmm.
so with that comes being more efficient. But what we have on the other side of that is now our bodies aren't moving. And with lack of movement comes this decrease in actual brain activity and function, the ability for us to cognitively do things like just walking, going upstairs, being able to sit down, because we don't do that as much as we start to age and don't challenge ourselves to do it, the body's like, okay, well, then I'm just not going to be able to function as well. And also strength and power, kind of independently and together as they overlap, is how the last, I guess you could say, quarter of our lives, when we look at our older age, like our 70s, 80s, and 90s, has a lot to do with functionality because of strength and power. And so typically people become more frail. So if you're not powerful and you're not strong, then you're more likely to fall, have accidents, be, committed to a long-term facility because you're not able to do everyday functions. So that to me is one of the most important things. And I think because we live in a very westernized world, we have a lack of those when really we should be emphasizing those, especially at midlife.
Yeah, that makes sense. I know. I think about, because we all work on our computers so often.
We
I
do.
just got one of those treadmills that
Yeah.
has made a difference. I
Yeah,
love
it
it.
makes a big difference.
Yeah. And then I guess I'd like to talk a little bit about sexuality.
Yes.
How does that change during perimenopause? I know one of the symptoms can be that it's harder to orgasm in menopause. So if you can talk a little bit about
There's a
that.
lot that has to do with the neuroendocrine. There's a lot that has to do with the brain function that occurs during midlife, and then also just physiologically and how our bodies respond to the decline in hormones. So hormones really are chemical messengers. They really tell our bodies what to do, how to respond, how well to respond, how quick to respond. And they also have this interplay or interaction with a lot of the organs of our body. So when it comes to sexuality, our largest sex organ is actually our brain. But we have neurotransmitters in our brain that also have to do with functionality, sexual desire, and function and pleasure that interact with our hormones, as we said before, progesterone, estrogen, and testosterone. So when you have a decline in that, what do you think is going to happen? The messages are not going to be as vibrant as they were before. And so that leads to how the brain kind of has a decrease in pleasure and libido, right? The desire to, and intimacy as well. But also for women, because we have a decline in estrogen, that means a decline of blood flow to certain organs such as the vaginal space, the clitoris. And again, that's going to now decrease sensuality. And also pain, because we have what we call atrophic vaginitis, which is where the vaginal tissue gets a little bit drier because of the lack of estrogen. So that usually will increase risk of pain. And so most women are just being like, that's okay. I'm not going to undergo the pain and therefore just decrease a lack of sexual intimacy. So it really is a lot of different things happening at once. And then the last thing that I would say too is the mentality and emotional space that women go through in this shift in perimenopause, which also leads to desire, intimacy, frustration, lack of tolerance between themselves and their partners. And so that is all happening as well. So do you see how it's like kind of like this like kind of mishmash of all these things happening? And we actually need it in a very multimodal approach in how to reconcile those things. And it can never just be a one thing. It can't be just like, oh, I'm going to take vaginal estrogen. That's great for the tissue.
Right.
But then what about for the brain capacity of what happens with sexual health? So that can come in a form of therapy or actually understanding intimacy at a different level because the hormones are not raging like they were in our puberty phase.
For partners, are there resources out there for them to talk to somebody when you meet with patients? Is it typical for the partner to join in this type of conversation?
I think it's very healthy for them at some point to be a part of the discussion. And the discussion shouldn't necessarily be that you have to fix it, but have an understanding of what's going on.
Yeah.
Now, when it comes to sexuality, there are a ton of couples that are actually sent to a sex therapist, right? So a PhD who specifically looks at what is happening in the landscape of sexual health between two partners and how do you rectify that. But a lot of times partners who have been together for some time, that this also creates a rift in their ability to connect. And so that can mean a difference in how we're going to now do this next chapter of our lives. And then also for them to see like just a therapist because they have different wants, desires, needs as well. Yeah.
And then when you enter menopause, do all these symptoms kind of go away or do they linger after?
They linger. I have had some women who have noticed a significant decline.
Mm-hmm.
And that may be because they were very aware of their sexuality before. And so going from a certain frequency or desire or level of sexual contact and
Mm-hmm.
intimacy has decreased. A lot of women, I would say, did not see the decline over time, the slow decline, because they weren't paying attention to it
Mm-hmm.
until they got maybe to a place they were like, oh my goodness, what happened? But there was a space and time that there was a decrease in how they kind of had this interplay in between intimacy and sexual contact.
And I know earlier you talked about HRT.
Yeah.
I think I've heard a lot about that as of late as well. How does that work with the body? Does it really decrease symptoms? Can we lean on
Yes.
that? What is that? How does
I
that work?
think that, hormones in general, when we look from maybe 20 years back, have really gotten a bad rap.
Mm-hmm.
And over the years, we've had to, in the medical space at least, had to take a step back and look at, okay, how do we restructure the evidence that comes out from this when we look at risk and benefit? There's always going to be a risk with taking something or taking something on.
Right.
But when we looked at that really in detail and really pulled back the layers, we really did soon see, very shortly after a study that was done in the early 2000s called the WHI, that the benefit to hormone replacement therapy or menopause hormone therapy was actually outstanding. Like, you can't really put the risk on the same platter as benefit.
Mm-hmm.
And when we look at the risk, there really is a smaller amount of communities of women who their risk exponentially goes beyond benefit. And so I think we now can say with certainty that most women
Mm-hmm.
will have benefit from utilizing hormone replacement therapy rather than the other way around, where it was much more a risk kind of category of this is not good for you. We are much in the day and age where we can say emphatically, hormones by large will be better for you, not only for symptom resolution, because that's clearly what they do, and that's usually why we're prescribing them. But
Mm-hmm.
now we're so far in the data that when we're looking at long term outcomes and benefits, it is outstanding and creates a platform for women to, remember, we said earlier, they live longer but in poor health, to live longer and to live in better health.
Okay. And is it something that you can take indefinitely, or is there a kind of a window where you got to
This is where
stop?
you'll start to see a lot of splitting in providers or people coming to an impasse of understanding, should I take it longer from the patient perspective
Right.
and also from the provider perspective of, do I continue my patient on this longer than what we typically used to see, which would be either 10 years after starting hormone replacement therapy or menopause hormone therapy, or not beyond the age of 60.
Okay.
We definitely can factor in, if you think about it, just hormones are not drugs. They're actually functioning parts of our body. So we're not giving you a drug
Mm.
in HRT. We're actually optimizing, buffering, supplementing your hormone level in a way so you're not having the symptom,
Mm-hmm.
but also providing your body the functionality to function at a better capacity than if it didn't have the hormones. So
Right.
that's the longevity portion of it, where people really should have the ability to decide if they would like to stay on it longer. And then it becomes a personal decision and a really nuanced conversation with their healthcare provider.
Okay. And then with just autoimmune kind of inflammatory
Hmm.
issues, is there any connection with that in
Oh,
perimenopause?
yes, there's such a strong connection
Okay.
because estrogen is an anti inflammatory,
Oh, wow.
right?
Okay.
So
Yep.
removing it from the body or the decline of it over this transition of perimenopause and menopause allows the body to be more in an inflammatory state over time
Mm-hmm.
than not, which is why we start to see with aging, specifically for women, when we look at them maybe against men, is most mood disorders, when we look at inflammation such as diseases that are autoimmune, start to really have more of an increase in intensity after menopause. And a lot of that has to do with the decline of estrogen because it really serves as one of its many functions as an anti-inflammatory and creates an ambiance within the body of decreased inflammation.
Okay. And I know we spoke earlier just kind of about brain fog and fatigue. So this is a little bit more general, but mental health.
Hmm.
I know this is kind of a big topic, right? But does kind of anxiety, depression, does that tend to get worse with perimenopause, or is there too many factors at play that we can't pin it to, oh, you're going through
Yeah, it
perimenopause?
goes to the discussion when we look at neurotransmitters, namely our neurotransmitters serotonin and dopamine.
Mm-hmm.
And these really have a lot of crucial aspects in mood and mood disorders. And the more that they're around versus not, that can impact our mood, right? When we look at depression and anxiety. And so
Mm-hmm.
for a long time, we would give medications that keep these neurotransmitters around longer,
Okay.
right? Because we knew that when they weren't around as long, that's when we started to see an increase or severity of these diseases. And so when we look at the relationship that estrogen has with these neurotransmitters, it does make sense that we actually do see more mood disorders diagnosed for women
Okay.
in between those ages of 45 to 55,
Mm-hmm.
which makes sense as you start to see fluctuations in hormones. And then also when you look at it from a study perspective, supplying women with hormone replacement therapy or menopause hormone therapy in the form of estrogen, typically you'll see more of an outcome of decrease of symptoms within mood disorders
Mm-hmm.
or a decrease in diagnosis as well.
Okay.
And so I think that women really need to look at one, being okay with understanding that there are mood disorders that occur. There is brain fog, there is executive functioning that starts to have a change. But you also get to decide, knowing that there could be some really good outcomes and benefits with using estrogen and progesterone. Not only so you don't use it to treat the mood disorder. I want to
Mm-hmm.
make sure that that's understood.
Mm-hmm.
But it really does allow the body again to function in the way that it needs to in its best capacity or best form
Mm-hmm.
when there is estrogen around.
Okay.
Yeah.
And then kind of off that, for those of us who maybe run hot or have higher stress levels in
Yeah.
your 20s and 30s, 40s, does that kickstart any of this either? Does that lend itself to kind of a worse experience? Or I'm just thinking like cortisol levels,
Yeah,
stress in general.
cortisol is again our inflammation hormone. It does a really good job for what it's supposed to do. It
Okay.
increases into the response or from the response of stress. But a stressor can be good or bad,
Mm-hmm.
and your body's equipped to undergo stress. The problem is we in a westernized world typically have more stressors than what we see globally, right? And that
Mm-hmm.
has a lot to do with the society we live in. It's very like go, 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 go. The food that we expose ourselves to, lack of movement and exercise also increases uh, the amount of cortisol that is released and sustained for a long time, right?
Okay.
So cortisol is designed to respond and then it should decline. But when it's raised and it stays up for a longer amount of times, that's where you really start to see problems with inflammation and stress.
Mm-hmm.
And so I think it should be looked at in duality or even more than duality of how are we treating our minds during this time frame and paying attention to it
Mm-hmm.
in a because of being around hormones that are fluctuating, but also giving yourself the luxury of saying, if I wanted to give myself back that hormone to a level that I can be better in mood and mind and mentality,
Mm-hmm.
then I should also contemplate that as well. And, I think the real thing at the end of the day is to say to yourself, I will never know how something's going to impact me, right? If you look at it for its risk and benefit and you know that the benefit outweighs the risk, I'll never know how I'll respond to it unless I try,
Right.
right? Hmm.
Yeah. And then for brain fog, kind of outside the obvious, getting a good night's sleep,
Hmm.
drinking water, um, are there any, I guess, are there activities that you can do to kind of
Hmm.
help prevent that from kind of taking over?
Yeah. So when we look at cognition in general, like executive functioning, from a hormone level, there's a lot of data that shows that testosterone has an impact on what our moods and what our executive functioning can do in enhancing that or
Mm-hmm.
optimizing that. But the other things that we can do is when we think of neuroplasticity in the sense of teaching your neurons how to fire differently, how to fire more active, that requires activity, right? And that really requires the ability for you to make those changes to turn your brain on differently. So neuroplasticity is the ability to form new levels and pathways by doing cognitive activities such as crosswords. Community helps, right? When we look at people in globally who do the best in older age through cognition, just looking exactly what you asked, are people who thrive in community, right? So forming friendships and connections with other people, taking on new hobbies, because it's teaching the brain to do something new instead of the same routine that we do over and over again. And so that comes into a sedentary mindset and how we have to offset that. So that really needs to be self-guided and something that you challenge yourself with. But as long as you're able to do new things, form new habits, that will keep the brain intact. One of the things that can.
Yeah. For fatigue, I think it's easy to say, "Oh, I'm so fatigued." I think we
Mm-hmm.
just throw that word around a lot.
I
But
even throw that one around.
I do. Yeah, I'm like, I'm always
Mm-hmm.
fatigued. But when it comes to perimenopause, or menopause and going through that phase, what does it actually feel like? Like, how is
Yeah.
it different than just
I've heard
saying, "Oh, I'm
different
tired"?
variations of this, and I think that they are very valid
Mhm.
because your body actually is undergoing a lot, right? And the body is very smart in the sense where if it's paying attention to something that needs to be attended to, a lot of times that can your body basically is like, I'm going to devote my time to this, and energy may have to kind of take a little bit of a second place right now.
Mhm.
But also, when we think of changes that go on with our thyroid, right? Our thyroid, rather, is very responsible for the metabolic function of our bodies.
Mhm.
And so, if that also has a change that we see in an endocrine perspective, that also takes a hit.
Mhm.
And then also, how our body processes glucose. And glucose has a lot to do with when we feel slumps throughout the day. And so, depending on how your body is utilizing it versus what you're putting into your body, right, which may not be the best energy utilizing forms of food or fuel,
Mhm.
then your body will take kind of that midday slump as well, which can lead to fatigue. And then also looking at our body's cells, right? So, the mitochondria of our cells or the cell's ability to replicate and produce energy that also comes with what you're providing your body, right? So the actual storage of energy, so that when it's time to expend it, you have the storage. That comes with exercise, which is why I always go back to those two.
Mhm.
So it's kind of like when I think of like a car assembly line and someone's not kind of doing their job, they're just not producing the amount of things that they need to do for that day. That does cause this bottleneck effect where everything kind of like slows down, slumps down, and so it really requires multiple different things in order to look at the whole picture of like fatigue. Because
Okay.
there are some times I think, and it should be, that's why I think it should not be dismissed when someone says that.
Yep.
Because it could be an actual condition that needs to be medically treated. But a lot of times it comes with this like kind of like story where people are like, I don't really kind of know why, or they can't really name it, but they know that it's happening
Mhm.
is to look at it again from a very like bird's eye view and saying, here are all the things that can contribute to. But you also have to take part in how we're going to explore these different fields and facets of what could be contributing to your fatigue. And there is no magic pill for it. And
Okay.
so all these things are going on. It's a really, if we think about the years that we said that perimenopause can occur, right?
It's a long time.
Can be like 3 to 7, sometimes 10 years. Then you
Yeah.
go through menopause and then your cell, and then you have the aging phenomenon in general. It's a lot. And so they do, know from science that at the age of 44 and 65, I believe that it is where your body really makes a very big shift in how it's going to function, I guess, for the next few decades.
Okay.
And so if we can pay attention to midlife a little bit more importantly and looking at it from a broad lens and doing as much as we can, overlapping and trying to tend to it in a different way, then I think we're going to get so much further. We're going to have a midlife where we're thriving while also preparing for that latter portion of our lives. And I think it really should be this journey that we are looking at it as the beginning of,
Yeah.
right? Rather than we started out by talking about how people begrudgingly or are weary of entering this phase. But if we look at it as kind of like, I get another opportunity to do this again, right?
Mhm.
Or I'm going to enter this in the best way that I can with all the tools that I have,
Mhm.
then that's how we can change what that narrative can be.
Yeah, I mean, because I think before recently, it almost felt like perimenopause was purgatory. And there was it's
Right.
just kind of this weird, awkward waiting
Mhm.
phase. Nothing really was good coming out of it. But
Yeah.
now that we have the tools and the education and we're starting to talk about it more, it can change, hopefully.
Absolutely.
And I know you spoke a little bit about thyroid, and I'm
Mhm.
curious, selfishly, my own family has experienced issues
Mhm.
with breast cancer and thyroid cancers. So I know and I've noticed that happens typically at this age.
Mhm.
So I know you've talked a little bit about thyroid, but with the breast, how does the breast tissue change during this time? Because it feels
Yeah.
like a lot of women who have breast cancer it feels like it's this age. Maybe I'm
It does. It
oversimplifying it,
does feel
but
like this age. I do think that we have better tools to identify breast cancer early. Early diagnosis is key.
mhm.
But everyone's body actually has cancer producing cells, and the body's immune system is able to suppress them much better when we're younger. And then as we start to enter that aging
Mhm.
kind of process, the immune system doesn't do as well, right? It's
Right.
aging. Now, I will say we may see it more where we see earlier diagnoses, but actually, one of the main risk factors or the most common risk factors for breast cancer is actually age. So the
Okay.
typical age is actually in the late 50s, 60s.
Mhm.
But I think we are living in a society where we see things more. But
Yep.
when we look at it from a statistical standpoint, is it really significantly increased or more than what we thought before? And so that I think is where we may not have a definitive answer that women are younger when they get diagnosed or much more. But the more important part of the whole breast cancer discussion when we think of perimenopause, menopause, and hormones
Mhm.
is that estrogen was always thought as this thing that causes breast cancer. We know that it does not cause breast cancer, but for someone who may have a hormonally, a genetic predisposition for breast cancer, that is, has a hormone receptive or hormone positivity receptor issue, then
Mhm.
yes, estrogen is not something that we are going to say emphatically you should start estrogen.
Right.
Now, women outside of that, which most women are,
Mhm.
can actually have a very good conversation about should I start estrogen as a form of HRT. The other nuance with that is when you look at what is the most common killer of women, it's not breast cancer, it's heart disease. And we usually see that after women go through menopause because they lack estrogen. And estrogen can be cardioprotective
Mhm.
in addition to aging, right? So there's a phenomenon around that. So if one wanted to take a risk on themselves
Mhm.
and say, what is the likelihood that I may die from something?
Mhm.
If someone were to say, you only get two choices, heart disease or breast cancer, what do you think you're most likely to die from? I would say, for sure, heart disease.
Mhm.
And so if I wanted to protect myself or be preventative in some fashion, in addition to other things, I would bet on, yes, I'm going to take estrogen to be more preventative than thinking it's going to cause breast cancer for me. And the other thing is, breast cancer has so much more tools because we've advocated for ourselves in breast cancer. So now we have mammograms, we know self exam. Early diagnosis is key because it is 1 out of 8 in a lifetime that women will have breast cancer. But because we diagnose it early, women
Mhm.
are living much longer
Right.
and living actually without breast cancer in the sense that it was diagnosed early and they did a modality or a treatment that they were able to live now cancer either undetectable or cancer free. And so that is inspiring that we've been able to do that in the breast cancer world. Now we need to start moving into how do we do that from a heart disease perspective as well.
Okay. All right. Well, I could talk to you about all these symptoms and what they cause forever, but we have to end at some
Yeah.
point.
Oh no.
Thank you so much for your
Yeah.
time. I really appreciated this conversation, and I know our audience will too.
Thank you so much.
Thank you.